Thank you, everybody, for coming. Can I be heard? Yep. All right. It's that balance between overheating and being heard. So if you can't hear me, then we can turn it on. First of all, thank you very much for having me. I make this visit once or twice a year, and I really appreciate it. So thank you to the centre for hosting me. So today. I kind of changed my mind as to what I was going to talk about at some point, I think. I can't remember when it was. I'm involved in a project with these two individuals, Siri and Pippa, that work with me in London, which is investigating, if you like, the social relations of the HIV care cascade. And it's nested inside a bigger project, which is funded with money from the Department of Health, to look at how to improve the HIV care cascade, to identify points in the care cascade from testing through to treatment of dropout, for instance, and the kind of interventions which might be mobilized to improve the care cascade. And from this perspective, they wanted some qualitative work. Now, we're in the middle of doing it, actually, so we haven't even, to be honest, got to the point of properly coding our data. So it's a little bit risky in the sense of I don't quite know where we're going to go with our analysis, but I've used this opportunity for this seminar in a sense to kind of force myself to start reading some transcripts and come up with some ideas. So I would, really appreciate your comments, your thoughts, your criticisms today, if you can see how we might take it forward differently or better. So to acknowledge the Health Protection Research Unit in HIV and STIs, which is the big program of work funded by our NIHR, which is our National Institutes of Health Research, and obviously Siri and Pippa that have been doing the bulk of the field work. Okay, so that's kind of what I said. Part of the problem that was constructed, if you like, in relation to the HIV care cascade in the UK concerned Black African and Caribbean men who are perceived to be finding most difficulty or most vulnerable, if you like, to difficulties of accessing HIV care, including antiretroviral treatments, and at risk of dropping out or not being retained into treatment. So we were pointed in the direction of including, in fact, framing the study, the qualitative study, in relation to the experiences, the accounts of Black African and Caribbean men, and especially those who are migrants. Again, which speaks to areas of concern in terms of vulnerability to engagement. So I'm going to just draw on some data, and I'm going to do this actually by focusing initially on a couple of case studies. So think of it just as a story in that respect, to say something about how these individuals account for their experience of care, as well as how their experiences of care in some way shape the kind of lives they lead. And this is what we mean in terms of the social life of care. Is there a clock so I know what I'm doing? Okay, so the Care Cascade. I don't know if, I guess most of us are familiar with the Care Cascade concept. Most people are nodding. I mean, there's an illustration of it. This is based on 2014 data in the UK collected by Public Health England. But as you can see, it's driven with the idea that one can see how individuals pass through various forms of kind of care, ultimately reaching undetectable viral loads. So it's very much a clinical and biomedical kind of definition of what a care cascade might be, with treated HIV kind of the ultimate outcome. Yeah, these are different slides. Oh, well, okay. So, I mean, immediately we can take issue with some of the assumptions in that kind of biomedical kind of envisioning of what HIV care should be or could be. As we said, it takes treated HIV as the outcome in terms of kind of viral suppression. I think the first point is that discourses of the kind of care cascade create certain types of patient identity and expectation in terms of what constitutes HIV health, in terms of what constitutes a good patient, as well as a good outcome, who's entitled, who's deserving, and so on. I think second, it probably doesn't speak very well to the multitude of social and environmental kind of effects or factors which can mediate people's access to care and or how they travel through that cascade. So we can immediately think of, for instance, care engagements being much more complex than that, much more relational, kind of including everything from bodily responses, interacting with technologies, interacting with healthcare providers and their systems, interacting with surrounding discourses or narratives of care expectation, interacting with laws and policies, and so on. So that's kind of a second immediate kind of concern or criticism we might have of the HIV care cascade kind of metaphor or idea, of course. And the third is that engagements with an HIV care cascade are not merely biomedical. The effects obviously transcend and can go way beyond the clinical and the biomedical kind of impacts that that care cascade might have. So I think at the outset, some of the assumptions which we were making in terms of how we approach this study, and which I hope will inform how we go about making sense of some of the data, is first of all that we envisage care engagement not as a simple problem of patient compliance or as a consequence of some prior essence of individuals' concern, but as the product of a relationship between people, systems, and environments. So in short, we're interested in mapping HIV care as a kind of practice of entanglement. Secondly, a second assumption is that, we're conscious, as I've said, that the care cascade gives primacy to biomedical kind of indicators of treated HIV. But we want to go beyond that. We're interested in illuminating practices of HIV care engagement which go beyond kind of biomedicine, which touch much more on the social life of care. And lastly, it's very obvious, people don't live their lives in a kind of care cascade kind of way, always. It's not that kind of squeaky clean. People don't move through this kind of linear, stepwise process. They ebb and flow, they go backwards and forwards, they change direction. The meaning of care changes in consequence. So it's much messier than that. So we see care as a product of a becoming, if you like, a series of engagements and re-engagements over time, and in fact over a long time. So those are some of the assumptions we're making in how we're moving forward, and I hope you'll see some of those kind of shape how we're going to talk about some of the data in a minute. That's a kind of summary of the project that, as I say, we're in the process of doing. So we're aiming to interview these many individuals. We haven't done that yet. So far we have about 29 transcripts of depth interviews with men who are Black, African or Caribbean. What we want to do then is to use our analysis of our wave one, once we've done it, to think about why we might follow up in a theoretical sampling way. We are introducing a few new cases to kind of build on elements of our data which we think are currently a bit thin. But basically we're talking today about drawing on the accounts, 29 accounts, depth interview accounts. Recruitment was in 3 clinics in London, supplemented by community recruitment. So that's kind of NGOs, community partners and others involved in the connecting up of people with HIV care and the delivery of care in some way. And today we're focusing primarily in relation to access and engagement with antiretroviral treatment, not other aspects of the cascade, such as testing and so As I said, that was the kind of ethos which shaped our sampling in light of this bigger project, which is why we ended up, through consultations with community experts and others, on focusing on these particular individuals for these reasons. So the sampling, in fact, was less kind of epidemiologically driven than it was through a series of expert consultation. And we're interested in kind of mapping a diversity, I suppose, of experience in relation to care and its disruption or disengagement. So as I said, we've done 29 interviews so far. This gives a sense, I suppose, very briefly as to who the sample are in terms of age and diagnosis and so on, and ethnicity. You can see that about 9 are talking about having some kind of inconsistent care experience with antiretroviral treatment. You can also see that very few are employed and that very many have very insecure kind of housing or home situations. So the backdrop, just remember, these are migrants. So at least 10 of these, at least kind of a third of the people we've sampled so far, are actually undocumented migrants. So these are people without legal status in the UK. They're either seeking asylum, waiting for decisions, or somewhere in between. So this creates a very fragile, very uncertain kind of living condition. For instance, you're not allowed to work, you can't generate income, you can't pay rent, you don't have a house. So this is a very, very fragile kind of social condition, which obviously relates to HIV care, as we'll hear. So I'm going to focus today, as I said, a kind of a preliminary reading from people's accounts, their own representations of their experience in relation to HIV care. From that, say something about what the relationality of care is. What is this entanglement which makes care or care opportunity or produces disengagement, yeah? And I'm going to do that to start with, at least for the first half of the talk, by focusing on a few case studies, which, as I say, you can treat at this point as stories, if you like, but they do connect with the thematic analysis which we've begun. So this is the structure, if you like, of the talk. It's in 2 halves. The first half relates to the idea of HIV care as an accommodation, as something which is accommodated within, inside a social life. And the second half talks more about HIV care as having productive effects, as shaping social life in some way. So we're focusing on the kind of themes which are emerging in our data of accommodation and production, a kind of reciprocal, recursive relation, a movement between HIV care and social life. Much more complex, obviously, than a biomedically infused representation of a stepwise linear care cascade implies. So let's start with accommodation. The ways in which HIV care is accommodated inside a social life in relation to other things, other vital matters of equal, if not more, importance. And I'm going to start with our first case, who we're going to call Godfrey, who is a Zimbabwean man. He's 44. He's currently undocumented in the sense of not having legal status in the UK, but he did have, and we'll come on to that in a minute. So I think the first point is a very obvious one in terms of how HIV and care might be accommodated, and this we all know, is that Godfrey came to kind of make sense of his HIV in relation to health through a felt sickness. He wasn't particularly engaged in a biomedical risk calculus kind of idea. It was because of what he felt. And that's what took him to seek help in relation to this kind of ill feeling, this felt sickness that he was experiencing. You know, I was sick, so I just went there like a normal thing. So this is a case of felt sickness. It's true of many others as well. So Godfrey initiated antiretroviral treatment upon his diagnosis after seeking help because of his felt kind of sickness, but he stopped shortly afterwards. So let's just have a look at how Godfrey accounts for this stopping of his ART. And he stopped it for 6 months before he re-engaged. And he rationalizes his stopping of treatment in 3 ways. The first is, well, he says he feels well, and so he questions, well, how can I be ill when I feel so well, actually? He kind of questions the biomedical evidence before him of his illness. And again, this is not big news. So he kind of deflects the biomedical reading of his health in some way. I mean, he invokes, as you can see in these extracts, ideas of denial as well. You know, I don't believe it's correct with the result. Can't believe it until you see it or feel it, kind of thing. So the first kind of rationale, if you like, on his stopping art or questioning the biomedical kind of value of that kind of care is how he feels. As is the second. He says that when he takes treatment, he actually kind of feels worse than he felt without it. And again, he's not alone in debating, obviously, the consequences of side effects and how that kind of impacts on a care engagement. The third kind of rationale he gives in his account, which takes us closer to the idea of accommodating care in relation to other vital matters in social life, is that he feels that it interferes with his capacity to work. That treatment side effects are important not simply because they indicate a sense of felt sickness or something like that, but they reshape his social life in a way which he doesn't feel capacitates him very well. He basically wants to work, as do others. So this is kind of a common theme throughout. So Godfrey's case so far kind of highlights treatment engagement, you know, that it obviously extends beyond a physical thing, beyond the bio kind of body interaction. We can see that already. But I think what's particularly interesting about Godfrey's account and how he takes issue with biomedical evidence, begins to question it, and kind of engages and then re-engages with it, is that he's actually a nurse. So he kind of takes issue with the very biomedical kind of knowledge and evidence which he is imparting or recommending to others based on his own felt experience. So I think it's quite a powerful case example for that reason. So anyway, he re-engages with ART after becoming actually quite ill. Again, his felt sickness after his treatment interruption brings him back. He went back for another checkup, and he talks about a very particular event where the consultant showed him a graph where he re-engaged. His account talks about him re-engaging, re-embracing biomedical evidence, and he remakes his sense of self and citizenship as a responsibility again as a more biomedically infused kind of patient. So his position changes. You can see that people ebb and flow, they go backwards and forwards, definitions change, and so on. So Godfrey's now re-engaging with biomedical care before him. He's re-responsibilizing himself, if you like, in relation to that care opportunity. You know, they advise me that, you know, you're doing bad things if you don't engage in the proper way, as only a nurse should know how. So that's Godfrey, and it's just a snippet. It touches on things we already know in terms of how the accommodation of biomedical knowledge or care opportunity is framed inside a social life. Okay, it's a negotiation. Let us continue this theme of accommodation for a moment longer and move to a second case study, who is Lucas. Lucas is from Ghana. He's a little older than Godfrey. He's 46, was diagnosed in 2003. And like Godfrey, he's an undocumented immigrant. He's about to start his asylum process. So he's in the position of all that insecurity I mentioned earlier in terms of lack of work opportunity and so on. And I'm going to use this case example just to hit home to illustrate how care engagement is a relational thing, that it's a product of a constellation of effects. There's many things at play that come together in a kind of an entanglement in Lucas's account, which frames his care engagement. It relates to his immigration, to laws, therefore. It relates to resources in terms of work, income, housing. It relates to his weak but nonetheless there connections with friends who help him out when it matters. It relates to non-human actors such as telephones, ambulances and hospitals. So let's just see. So he outstayed his visitor's visa, and so the themes of immigration and legal status are really the kind of the primary actants in Lucas's narrative. He describes his life in the UK basically as very tough. It's difficult to support his family and so on, and in accessing care services, especially, you know, given his very real fears of arrest. And there's a real kind of atmosphere of that, by the way, amongst people with undocumented status, or even migrants with status, if you like. This fear of arrest at the point of care, and so on. So this is framing Lucas's account. Anyway, one day his health deteriorated. He came back from work one day. He felt very dizzy. He felt very weak. And he says he had no doubt that something was going on. So his immediate response was to seek help from a friend. And this is somebody he knew from school days, actually, from back home. And this is an instance of what we are coding in our data at the moment as friendship care. And it is actually emerging as a very important dynamic of the care engagement relation. His friend advised him to go to a GP, or to a walk-in clinic, in fact, because his GP was so far away from where he lived. But Lucas was scared, given his illegal immigration status. So his friend chaperoned him, took him to the GP, and helped him out. And like others, his eventual kind of connection with care services was brought about by a felt sickness, you know, a crisis in illness, basically. He ends up kind of collapsing, and his friend basically has to call an ambulance for him. He gets to the hospital. I realise I'm on the wrong slide here, but anyway. And Lucas at this point is in and out of kind of consciousness, in fact. He also has limited English, and his friend is still there. And basically his friend is acting as a kind of translator, if you like, between the patient and the care. In a way, his friend is enacting a care relation, connecting up Lucas into some kind of network of care. As he says, he didn't know what happened. He's relying on his friends for translation, literally, including his diagnosis. He said, "You are not positive. That does not mean, you know, that this is a good thing." What happens next really accentuates the kind of fragile social conditions of Lucas's situation, actually. He's referred to a hospital, which is well known as a hospital for people living with HIV and HIV care. And while there, which I think is obviously a very stark illustration of stigma in action, is that he's evicted by his landlord while he's in hospital from his house. He doesn't want me in the house. This is the telephone call he gets while in hospital. "I don't want to see you in the house again. Don't come back. You know, I will take away your things." So what we see here building up really in Lucas's story is a kind of a narrowing of care opportunity. His resources really are imploding. His housing, you know, his health, his sense of citizenship, security, his capacity to communicate and negotiate, his sense of agency, it's kind of imploding. It's not a free-flowing access or cascade of HIV care. It's becoming a kind of a mountain of steps to climb for Lucas. you know, he feels stripped of everything in a way. He says he feels shamed, he feels shunned by those he knows, and there's a lot of construction making in these migrant accounts about Africa as the other, okay, and about being African um, having a particular kind of context making effect in terms of what you can and can't talk about and whether you can disclose your HIV and just the full force of stigma. And he goes on to describe that in terms of how he felt shunned by his friends on leaving this hospital, which we're calling Hospital A. They don't want to be associated with me, for instance. Again, it's friendship care, which creates a lucky safety net. It's a chance meeting for Lucas. A friend who he's helped in the past, and he's helped his friend find work, and whose wife he also helped with her own migration to the UK, just happens to telephone, as he describes here. You know, I told him I'm on the streets. He said, I heard you were ill, that somebody told me you were in hospital, in Hospital A. This is the one known for people living with HIV. And he goes on to say, well, no, it wasn't Hospital A, it was in Hospital B, and so on. But he invites him in, there's an open door, he offers him somewhere to stay momentarily, at least temporarily. They saw a different body, but he can't tell them what's going on because his housing, in effect, depends on it. Then ensues quite a detailed story of how he has to manage his HIV and prevent the deductive disclosure of his HIV, living with his friend in this temporary accommodation. He has to hide, he has to lie, he pretends to take long walks in order to take his meds, or when he has to go and make medical appointments, he pretends his illness is something other than what it is. All these are strategies, obviously, in some way of passing, of appearing at least normal enough not to be questionable. This does have an impact in terms of his adherence at times, which he also goes on to kind of explain. So with Lucas, I hope that brief kind of case study can illuminate something of the relationality of care, that there's a lot of things going on here. There's a multitude of factors which are coming together in a hit and miss way, which produce a care engagement event or not, as the case may be. And these are just some of the things across Godfrey's and Lucas's account which are at play here and which are producing this entanglement. So that's the first point, that HIV care is an accommodation inside this social relation which I've described, where here, in these accounts at least, immigration is being cast as a kind of key actor. So, having seen a little bit about HIV as an accommodation, can we move to the idea of HIV care being a production, having productive effects on how social life is made? So the first half, Godfrey and Lucas, has been about, I guess, how social life affects how HIV care engagement is made, and now we're moving to the idea of HIV care engagement making a social life. And I'm going to draw a little bit more thematically across some of the accounts now to do this. And again, some of this won't be news, obviously, to many of you in the room. I think the first thing which jumps out in terms of emerging themes, in terms of how care is valued, is this theme of what we're calling care beyond the virus. That accounts place value on care which extends beyond the biomedical things linked specifically to viral care or viral control. And that they don't link this kind of care only to community-based organisations, they also link it to the clinics, the 3 clinics in the study. And as you can see, those are extracts which speak to that. But again, it's about vital life concerns. It's about care taking heed of people's actual, if you like, situations, such as those linked with immigration, housing, work, money, food, family, and so on. These are the vital matters in social life to which care might respond beyond the biomedical. Let's ignore that. A linked point is that care is valued for the social relations it enables. And this is I think this is a key point for me, and we can talk about this a little bit later. It's striking, for instance, how often the clinic is described as a place of home, as the people within that as a kind of resource, like a family. That the connections people describe with the clinic are described in very personal terms. And obviously a home is not just a physical location, this is the point being made, it's also a safe haven, a place of relative security. And you've got to remember that most we're interviewing are a long way from home. Many we're interviewing have very weak kind of social network connections whilst in the UK, and within some of their own kind of networks feel unable to kind of manage their health concerns, as we've already talked about with Lucas. So the clinics, as well as the community-based organisations providing care, HIV care, they become a known, a familiar, a safe and trusted place of social connection. And that's really, really important in a life which is otherwise characterised by a lot of uncertainty and even hostility. So there's a familiarity which is built up around the clinic and this sense of safe haven and homeliness that it provides. And remember, you're talking decades here in some cases. So the doctors, the nurses, this is Lucas, they are my friends. They're looking after me at the moment. I told him I will never ever go to any other doctor. Now he is a friend of mine. I will never leave him. There's this crazy sense of gratitude which people have in receiving some care, which is obviously very, very telling in terms of people's sense of entitlement and so on. As I've said, it's a personal connection. This is Thomas. He was diagnosed very young, and he basically likens his consultant to the role of, well, she was like my mum, basically. You know, she saw me every month, she took care of me. His account very much is about growing up, you know, with the clinic as a family. He talks about the clinic as a kind of family environment. She was my absolutely everything. Okay, so with this care beyond the virus, we're emphasising the social relations in care, basically. There's very high value placed on small things like help with food, small grants, for transport, that kind of thing. But what I think I'm arguing is it's the social connections which are enabled through this care opportunity which are fundamentally important and come across as particularly vital, as we can see here. It's kind of more of the same actually, isn't it? But there's two dimensions we might pull out from what we mean by this social relation which is being created by this care connection. The first theme we're currently coding at the moment as open society. A sense that these safe havens, these clinics, these spaces create a sense of openness, of freedom, a release from having to hide, which otherwise might be the case in people's other social networks to the extent that they exist. So we're calling that open society. You can see here, and we need to focus on this much more in our analyses in a much more meaningful way, this kind of how the accounting constructs Africa and African life as a kind of source of othering in this respect. It's a very interesting kind of narrative to explore, which we will do as I think we go through. So a sense of open society. And I think a second theme we can code underneath this idea of care as a social relation is what we're calling new sociality. You know, people are making new connections here. They're making friends, they're making connections with people out with their normal networks. Actually, they're meeting people. I mean, a lot of these people are quite isolated on their first arrival in the UK, for instance. So there's a sense of what we're calling, that's not our idea obviously, a theme of new sociality connected with care. And I think taking these things together, we can see how care is shaping social life and not merely being fitted within or accommodated inside a social life. It's making social life through this sense of open society, new becoming, new sociality, and so on. In fact, people are very much making and building a life around and in care. And here we see care, if you like, having a structuration effect on the kind of lives which become possible, which become capacitated through this care connection. Some people talk about it like a job, okay? Like they structure their week around their care and get everyone's nodding. This is no news. I hope you're not bored. You know, they structure their week around their care engagements. Tuesday I go to A, then Wednesday I go to B, so Thursday I can go to C, and Friday, etc., etc. It's a busy week. It keeps me active, except for the weekends where I might just chill out and not do any care. So, I mean, this is a kind of, you know, it's a fairly flippant example to illustrate how care is making social life, structuring social life in a particular way. It's capacitating a particular way of living. Just to go back to Godfrey, I mean, we noted that many of the people we're interviewing are not in employment. You know, they have time on their hands. I think that's the other thing. And care engagements have a kind of, I mean, I think that relates to why there is time to enact care in this way. Godfrey, who had a job, we heard about him earlier, he was our first example, then didn't, because his wife, who has European citizenship, left him. And that put him back into a very precarious situation where he didn't have a legal claim so much on residency. And there's a whole sequelae of the normal experience I've kind of described, what normal for some, is that he lost his job as a consequence. He lost his housing, actually. He became homeless, and he kind of got more engaged in care because he needed it. He needed that social support. And he basically says that with the time on his hands as well, he's engaged with care. He's now thinking of a career in care. And I think it's interesting, there's quite a few of our participants that are very care engaged, if you like, in this way, that are, as I say, making a social life in care to the point of building a career trajectory and a future around it, based on it. So I'm almost done. But I just want to pick up on, so that's accommodation and that's production. And those are just two themes that I'm working with currently with this data. So I'd be interested to know whether, you know, some of your views on that. But before we kind of summarise, you know, because the social care that's provided beyond the virus is so vital, I hope that's really clear, its taking away becomes really, really strongly feared. You know, there's a real panic and anxiety around this kind of social care being disrupted. Because as we will appreciate, it's disruptive to a life. There's so much invested in it. And what we have are quite strong themes across the accounts of a cascade of care rationing operating in the last few years and in these people's experiences of their care engagements, in which funding flows for care are forever narrowing. And this reduces the forms of care engagement that were possible. And here's a fairly classic kind of example of this kind of account. You know, once it was special, you were catered for your every need. And critically, what we're talking about here are needs which are indirectly associated with the biomedical or beyond it in terms of care. The funding cuts is kind of such a big thing. The patients are brought into this discussion with the consultants about the problems of the funding cuts. It's framing people's care engagements in a way now than it wasn't a few years ago. So there's an awful lot of concern and fear about this. So accounts talk about there being rationed time, rationed frequency of contact, rationed expertise. No, you can't see a specialist. Now you have to see a generalist and so on. Rationed community support, especially. And there's now kind of a growing kind of history of long-standing community peer-based projects providing HIV and social care in the UK that have been folded, scrapped, or that are in transitional funding, for another few months, and who knows what will happen then. So it's the care which is most valued, the care beyond the virus, which is being rationed most heavily. And this is just another example of what's happening here. So basically this is a real concern, and I think what we're arguing or beginning to think is it's indicative of a remedicalisation of HIV care, basically, which is what Peter is describing here. So I'm going to make some conclusions because I've done my time, I think. So, first of all, HIV care is at once an accommodation in and a production of social life. We are seeing it, although immigration has been articulated here as a primary force, it's amongst many effects, many actants, and I really kind of emphasise that. That we can see this as an entanglement of many things. And we saw this in Godfrey and Lucas's accounts, for instance. We saw a multiplicity of things coming together at particular moments. With Lucas, a whole mixed bag of ambulances, telephones, a chance meeting with an old friend, friendship care, which provided a resource for him to get access to care and so on. I think the key point is these themes of new sociality and new society, the sense of security and homeliness which care beyond the virus provides, particularly for people who are in transition or uncertain in their life environment, such as those migrants that we're interviewing. And obviously, the other thing we're looking at is this idea of care rationing, undoing the very care which is valued most, and which presumably is also productive of hooking people into the biomedical aspects of their care. So we might, I guess, consider what the implications of that are in terms of the kind of care which should be constituted and protected, in this situation. And just to make a general point, in a way, I don't think it's that we need to do anything new. We probably know what to do, and it's probably been done for many years. The question is how to protect it, and how to build on the social care work, which has been done so well, particularly by the community-based organisations, but also by the clinics, which I think is really interesting. So those are the transcripts I've been reading over the last few weeks, Jake. And I think I'll stop there.
It's an odd sensation, so you'll be speaking to the mic, it needs to be on. Yes, it does make sense. So, questions?
Thanks a lot, Tim. Just a question of context while people are thinking about deeper things. The people who are undocumented in the UK, do they have access to care and treatment as people who are documented migrants or other citizens?
They do. In theory, everybody should have access to HIV treatment. And everybody should have access to a GP. That said, for some of the reasons we've already mentioned, that isn't easy to do or connect up, particularly with GPs. But I think also, this idea of a fear of possibly being picked up by an immigration officer on your way to a clinic. That's a real fear. It was just before I left, there was kind of this announcement that the NHS, the National Health Service staff, would be expected to hand over information, personal information, on suspected undocumented migrants to the immigration office. But in theory, HIV treatment is free and available to all.
Hi, Tim. First, I just want to say that was a great lecture. My name is Cheyenne, and my question is, what kind of implications do you think these sorts of findings would have on patient-centered care, and particularly the practice of healthcare professionals towards migrant patients?
Well, I think what's happening is the nuts and bolts of a relatively good care system are being undone. And I think one of the consequences is that people's engagement with the biomedical and clinical aspects of their care will possibly fall apart in terms of their adherence, their retention, and so on. So I suppose how I imagine we'll end up analysing our data and feeding back to the Health Protection Research Unit is by thinking about how one can protect the social interventions which, if you like, form the glue in keeping everything together, including in the space of the clinic. And you probably know as well as I do what these kind of interventions might be, but just to give you an example of one, in one of the hospital sites, it's just having 3 to 4 peer navigators on site to work between patients and clinicians to help navigate complex systems. These kind of very practical things, but these are the kind of practical things which have been taken away by the funding cuts. But yeah, but I mean, it's not all doom and gloom, but I think if you look at the atmosphere around migrancy in relation to just entitlements generally in the UK and across the globe, I think there's reason to be, concerned.
Tim, thanks for that presentation. I'm actually going to, I was thinking about, starting with the cascade of care, and it's making me think about, the power of quantification and making visible certain data and then hiding others. And I think your talk very nicely reveals other things which are clearly very important to people affected by HIV, and particularly in this target population. And I'm wondering if one strategy is, other than through the project we're doing, so what is going through my mind is, and it could be futile, but I'd be interested in thinking about services and organisations making visible some of these aspects of the multiverse of care, such as, the number of people who are in work, or who have social contact in their work, or who feel support, and perhaps not, the starting point, I mean, it's so bloody dry, but, quality of life measures. But the problem is when you start with this top-down measurement system of outcome is undetectable viral load, all these other things are lost. And actually, if you want someone to have a healthy life, they need a range of access to these.
I think it's a good point. No, I mean, the first thing I agree, it's amazing what an epidemiologically, clinically kind of image of the cascade hides, and what it makes invisible. It's incredible. That is a success story when you look at the UK. 90% of those in care are, etc. And that is how that is kind of rolled out usually. So there's so much kind of underneath that. I really like your idea of inverting that way of communication by producing alternative cascades. Although cascade is probably the wrong metaphor. Yeah, I mean, Peter's nodding, because we're dealing with entanglements here. So quite how you image that, I'm not sure. But I really like the idea of maybe building on some quantification in that kind of graphical representation of some of the complexity we're seeing here. I mean, obviously you see it performed in other ways. So, Stop the Cuts campaign in the UK is kind of massive. It's having impact. It's at least enabling some peer education community services to be protected, if only for months at a time. And that's also very visible. So it's not that we need or should rely on quantification alone.
Thanks. Hi, I'm Vendela from Sydney MSIC. Thank you so much for this interesting talk. I'm kind of wondering on the cross-cultural aspects of your analysis. If you're coding for some of the cross-cultural perspectives and in particular, I was thinking in terms of the sense of belonging and like the social connectedness. It might be somehow different for people who come from much more connected societies and communities than the Western individualist cultures are.
Yeah.
And maybe more broadly, maybe that's another question on implications, whether whether there are implications how to approach migrants in healthcare, whether the idea is to create a culture sensitive service, or whether just like an open service with no stigma attached is what we're looking for.
Yeah. I mean, the kind of short answer is I agree with you. I think, yes, how people account for their sense of family is likely to be different. It's also kind of indexed very much to people's situations now, which cross-cut those kind of ideas. And yes, again, I mean, it's a very peculiar study in a way, because I think the sampling for our study is a very kind of, it's a bit mind-boggling and not very sensible where we ended up. I mean, there was a logic to it, but yeah, when you look across the data, there's so much differentiation in terms of, you know, different cultural scripting of experience and so on. I think we're going to have to pull that apart. We are absolutely going to have to pull that apart. I mean, interestingly, we have, in a way, as a kind of negative case logic, but also because there was a very keenness for it to include this subsample because they were also considered not very well voiced and also open to disengagement in care, is we have a kind of almost like a comparison subsample of white heterosexual men in this sample, which is why the sampling begins to look a bit odd. But it could therefore be possible to look across these kinds of accounts. For instance, in terms of how ideas of Africa are invoked, or family, and so on. But I kind of agree with both your points. So it's a bit of a rambly answer.
What you've been speaking about has really reminded me of the work we've been doing in needle and syringe programs, where there isn't even a cascade of care. There's one measure of effectiveness used, which is receptive syringe sharing. And the qualitative work we've been doing and the quantitative work we've been doing with clients is trying to show that entanglement and the social glue, the care beyond the virus that the NSP workforce does in so many different ways. And the tool that we've used is a program logic tool to show that if you want to achieve reductions in receptive syringe sharing, you need to explode all these other things that are related to that, right back to the highest levels of prohibition around drug use and all the way through. And within that, some of our quantitative work has showed a particular subgroup of people that might be similar to the sample you've been talking about here, with highly complex chronic needs that will require additional and different resourcing and support than perhaps the typical client, or indeed the client at the end of the bell curve, which is another tool we've been using to talk about it. So I wondered, in your era of reduced funding to clinics and to CBOs, if there's any notion of being able to tailor services with an understanding of that entanglement you speak of, but also perhaps in more words that are functional for health departments of complex chronic need clients.
Yeah, I think there's a kind of, I think there's a very real sense of just how intense the frequency and the quality of the content has to be for some of these and less others. I'm kind of not aware of kind of formally how that kind of rationing decision is playing out in terms of service provision, to be honest. But certainly in our beginning to talk about this data, and now we're kind of generating it, that's definitely the kind of perspective you get back from providers. So there are, you know, people that are much more secure in their housing and their legal status and their everything else, that might well be used to this special care of the days gone by, but probably might be less requiring of such intense social care now. So I kind of agree with the logic. I mean, I suppose rationing is an inevitability. So the question is how you do that rationing, you know, in a fair and just way. Yeah.
Can I just make
Yeah, practice what you speak.
Rules, yes. I guess it's a really obvious point, Tim, but as people like Sue have been arguing for years, this notion that the biomedical is somehow outside of the social is a nonsense, and even the daily practice of taking a pill is, of course, a highly social as well as a biomedical activity. And it seemed that it was a really nice illustration of that. I'm not sure if it was Godfrey or one of your other participants who, when he moved into a house with his friend and his friend's wife, but didn't disclose that he had become positive, and the difficulty he had taking his pills every day, which is, of course, according to that biomedical model, that's all that's required, and yet it had all these social implications for him. He had to go out, he had to kind of create walks to go on in order to, which I think was such a nice illustration unintentionally of this possibility of separating the two.
Yeah, absolutely, I agree. Yeah, no, it's a good instance. Yeah.
Okay, I'm getting the wind-up signal. Look, thank you, everyone. It's lovely to see such a great turnout, and a pleasure to have you, Tim. Thank you once
Well,
again.
thanks for listening.